Good noon. Our next session will be on depression with somatic syndrome, a challenge by Dr. M. Sureshkumar. The chairperson on the session will be Dr. Satyanathan, retired Director, Institute of Mental Health, Chennai, retired Professor and HOD of Ramachandra Medical University, past President of IPSOCON21, the psychiatrist with 30 years of experience in the field of clinical and teaching. His special areas of interest are geriatric psychiatric, de-addiction, telepsychiatric, crisis intervention, marital counseling. He has received Lifetime Achievement Award from Indian Medical Association, Chennai on 26th of November 2017. I welcome, sir. I welcome Dr. G. Amuda, Assistant Professor in Madurai Medical College, to hand over the memento to Dr. Satyanathan. Welcome, sir. Now over to the chairperson.
Good afternoon, every one of you here, and at the outset, I'd like to thank the organizing committee and then the chairman and the honorable members of the Indian Psychiatric Society South Zone for asking me to chair this session. And then here is Dr. Sureshkumar. It's a good friend of mine. Before we just Suresh joins in, and whether the presentation is painful or non-painful, the somatic symptoms are basically a challenge in psychiatry, because to the patient, the somatic symptoms are very, very important. So they always focus upon the somatic symptoms. And underpinning psychological symptoms, they fail to recognize and all. Precisely the same thing happens with the general practitioners. You know that 60 to 70% of our patients go to general practitioners, and many of them who may not go for depression, but they may have multiple somatic complaints. Even in the beginning of my career, when I started, then patients I will be always trying to highlight the psychological possibilities of the presentation, but they will always Kuttal, Kodachal, or whatever, they will always be talking about their pain and all these things. So the primary reason is that many of the primary care physicians or many of our medical own specialists from other specialists, they fail to understand. So what happens is that many of the somatic symptoms presenting with depression goes either underdiagnosed or undertreated and all these things. So what happens is that it leads to chronicity, and then leads to suicide, and then economic burden, and mainly the quality of life of the patient suffers and all these things. So any somatic symptoms medically unexplained, we have to think in terms of a possible psychological overlay or something like that. So what is the need is that Hamilton was mentioning that about 60 to 70% of the women who present with multiple somatic complaint with anxiety, they have an underlying depression and all these things. But again, even if you diagnose depression, then how many of the people respond to the antidepressants is $1 million question that one has to ask. So probably Dr. Sureshkumar will try to highlight whether the somatic symptoms in depression is a maladaptive neurobiological stress response or what. So I'll hand it over to Dr. Sureshkumar. Welcome, Dr. Suresh. We are missing you here.
Sir.
Suresh, go ahead.
Am I audible, sir? Am I audible?
Yes.
Can you hear me?
Yes, sir.
Yeah, you're audible, Suresh. Please go ahead.
Thank you. Good afternoon, and I think I miss being in Madurai. First of all, many thanks to Chair Dr. Satyanathan. Sorry that we starting it late because I just had a session just before this, and then I was asked to pitch in at the last minute because the speaker was supposed to speak on empowerment, was not well. So last minute, yesterday I had a SOS call and I had to fill in that as a science committee chairperson. So I got delayed in the process. My apologies for that. So thank you very much, sir. Satyanathan said to have you as a chair. You are my teacher, mentor. To have you, Guru, as my chair, it's a blessing for me. So what I'm going to do today is to talk about depression with somatic syndrome, how this is going to remain as a clinical challenge for all of us. And I think, first and foremost, I want to understand the relationship between somatic symptoms and depression. So, if you look at the clinical diagnosis of depressive disorder, let's say you use DSM-5 as a way to diagnose a major depressive disorder. There are usually 9 symptoms that are there, which are there in the PHQ, which is just a translation of what is found in DSM-5. If you look at the 9 symptoms, the first one is a depressive mood. Without any doubt, you don't make a diagnosis of depression without the depressive mood. That apart, there are 8 more. And in the 8, you look at sleep, energy, and appetite. The 3 things are related to somatic symptoms. In terms of insomnia or hypersomnia in sleep, in terms of decreased energy, which is fatigue in energy, decreased or increased appetite. These are the 3 important symptoms of the 9 symptoms in depression. This apart, there is this anhedonia, there is this guilt, there is this concentration difficulties, there are psychomotor disturbances, and of course suicidal thoughts. This defines the clinical syndrome of depressive disorder. So even in the very definition of depressive syndrome, you have 3 somatic symptoms figuring in that. If you look at the rating scales, many of the rating scales, including the popularly used Hamilton rating scale, have very, very strong 5 items which lean on to somatic symptoms. So somatic symptoms are always conceived as integral to the diagnosis of depressive disorders itself. So historically speaking, Wernicke, the famous Wernicke's encephalopathy, Wernicke was the first person to describe that in people with depressive states, there are bodily sensation disturbances. And he talked about it as vitality disturbances. And the vitality disturbances can be confined to some organs, for example, stomach, resulting in appetite loss. It can be in the chest, leading to some chest pain. It may be in the head, leading to heaviness of head and headache. Or it can be completely in the body, resulting in fatigue. The first description of vitality disturbances was noted down by Wernicke as part of the psychopathological phenomenology of depressive disorder. Later on, Kurt Snyder elaborated it and said bodily sensations are critically important to make a diagnosis of what he called as a cyclothymic depression, which is very popular then. So those kind of terminologies have gone away, but still the somatic symptoms have become integral to the diagnosis of depressive disorder. That's the first point that I want to drive. Second, if you look at somatic symptoms in depression, Dr. Satyanathan was alluding and saying how relevant it is, how people are preoccupied with it, how they will present it to you again and again. They sometimes confuse you. So, whenever a person with depressive disorder has a bodily symptom, you want to know what is that word you can use. There are many words we use in psychiatry which can be very confusing for a beginner. We use a word like somatic symptom, bodily symptom, somatized symptom, medically unexplained symptoms, functional somatic syndrome. So you can use different kind of terms which can be confusing, but if you are going to use bodily sensation disturbances and want to refer it to a person with a depressive mood, then you better call it as a somatic symptom. So somatic symptoms are the preferred terminology when it comes to using for people with a lived experience of depressive mood. When the depressive mood person has a bodily sensation that is perceived as unpleasant or it is worrisome for him, you call it as a somatic symptom. These somatic symptoms can be localized in certain parts of the body to certain organs. Like I said, how Wernicke called it, confined to stomach, confined to head, confined to chest, or it can affect the whole body, as he said, can be called as fatigue or loss of energy. Now, there are other bodily disturbances also, like which are found in the very integral diagnostic part of depression, which is sleep disturbance, appetite disturbance, and these are all also called as somatic symptoms. So, but the critical point for a clinician is not just to understand whether the person with depressive disorder presents with somatic symptoms. That's very important. More important than that is whether the symptoms are painful somatic symptoms or non-painful somatic symptoms, because that distinction is going to be not only important in terms of, like how you're going to manage it, it is going to be of prognostic significance. So pain is a very important component of depression, and often is the most important component of depression and most prevalent component of depression. And I think understanding whether the somatic symptoms have this painful concept associated with that is something we as clinicians have to discern to begin with. So the point number one is somatic symptoms are part of the diagnosis of depressive disorder. We prefer the term somatic than anything else when it refers to depression. But in the somatic symptoms, the clinician should pick up and say whether it is a painful symptom or a non-painful symptom, which is important for its diagnosis, treatment, and prognosis. Okay, what are the usual common somatic symptoms that are presented in a person with the lived experience of depression? The commonest one is headache, followed by backache. Headache and backache are very important painful somatic symptoms which a lot of people with depressive disorder present, followed by chest pain, shoulder and neck pain, soreness in more than half of the body's muscles. So when you present in an outpatient clinic, particularly in a primary care setting, if you are sitting in a primary care setting, when people are beginning to evolve into the diagnosis of depression, when it is not very clear, when they present to the clinic in the primary care settings, many people are going to be coming up with this common somatic symptoms of headache, back pain, chest pain, neck and shoulder pain, and soreness in the body, half of the muscles. This apart, there could be other somatic symptoms. Persons can complain about dizziness, or tightness in the chest, or muscle tension, or difficulty in breathing, or shortness of breath, and palpitations and increased heart rate. Some of them are anxiety symptoms. Generally, in a primary care setting, it is the anxious depression which actually is predominant. Very difficult to differentiate whether it is anxiety or depression. So probably you make a diagnosis of mixed anxiety and depression, which is what ICD used to call it, anxious depression in the yesterday's diagnosis. So this is how the common somatic symptoms are presented in a depressive disorder, particularly in a primary care setting. So I think why we have to allude and apart, like understanding why we are devoting a session to it and talking about somatic syndrome and depression is because the negative effects of somatic symptoms is having a greater influence on the diagnosis, on the treatment, as well as on the prognosis of depression. First and foremost, let's come to the diagnosis. They can mask the psychological information relating to depression. People presenting with painful somatic symptoms or other somatic symptoms are used to be called as masked depression in the past. I remember as a young psychiatrist, nearly about 40 years ago, when I heard the first presentation from the erudite scholar Dr. A.V. Rao, Dr. Venkova Rao. I came all the way to Madurai to listen to a lecture. His lecture was on mass depression. That's the first time I heard about mass depression. Such a scholarly talk. I still remember the details of what he spoke. He said many of the people in primary care setting with the diagnosis of depression would actually present with mass depression because they wear the mask of a somatic symptom. They present you with a headache, they present you with a backache, but indeed, if you are careful to go and examine in detail, if you can unmask that, you can probably get the psychological information that will lead to the diagnosis of depression. Today we don't use the word mass depression, but yet I think it's a very useful thing to say. When people predominantly present with somatic symptoms that can mask the diagnosis, people can land up in a medical setting, spend enormous amounts of money, or even psychiatrists might miss the diagnosis, may call it as a somatoform disorder or medically unexplained symptoms, and then they will figure out, indeed it may be a treatable depressive disorder when they get the psychological information flowing in from the person. So for diagnosis, very important. Second, if the person has depressive symptoms, that depressive symptoms is going to prolong the duration of depressive episode. Because people with somatic symptoms, particularly painful somatic symptoms, live with a depressive episode for longer duration. Instead of 3 months, it may last for 9 months and 1 year. Similarly, the severity of depression has a very strong correlation with somatic symptoms, about which I'll allude in more detail. So somatic symptoms are very important in increasing the duration of depressive episode as well as increasing the severity of depression. 3, even if you start to treat them with antidepressants, often these people with somatic symptoms do not remit completely. We do know in the treatment of depressive disorder, remission is the immediate objective. Unless you obtain remission, remission is defined as virtually having no symptoms. A Hamilton score of, like below 7. Or, if you really say there are no symptoms, almost is asymptomatic, only then you say it's remission. But then the person having some residual symptoms, which you can say he's improved, but still he harbors the residual symptoms, mostly in the nature of somatic symptoms, even after the depression has been aggressively treated, this residual symptoms can pave way for relapse and recurrence. So I think our goal of recovering the person from a depressive episode is completely jeopardized if you do not address it very well. So somatic symptoms are very relevant because you can miss the diagnosis, or you can have a prolonged depression episode, or you can have a severe depressive episode, or because it's going to have residual symptoms, it can contribute to relapse and recurrences, interfering with the recovery process. So that's why the relationship between somatic symptoms and depression is so very vital. And I think there's a lot of research that has gone on, particularly in Asia, in Korea and other places, where they've started to study the relationship between somatic symptoms and severity of depression. And Korea is a country which has come up with a scale, which is a scale that combines depressive symptoms as well as somatic symptoms. They have the DSS scale, which has a combination of depressive subscale and a somatic symptom subscale, because they recognize the importance of somatic symptoms in depressive disorder. So there they figured out somatic symptoms are extremely relevant for late life depression. Persons presenting at older age, geriatric depressive people. You use a Cardinal, like a kind of a scale to unearth depression in older people. Many of these people with late life depression have indeed pretty good somatic symptoms. Even if you address the comorbid physical illnesses, they might have comorbid physical illnesses like diabetes, hypertension, lipid disorders and cardiovascular disorders, arthritis and whatnot. Even if you adjust for all those physical illnesses, yet there are some unexplained medical symptoms, somatic symptoms, which are part of the depressive disorder. So somatic symptoms, independent of physical illness, is closely associated with late life depression. So that's a very important factor that you need to remember. Whenever you see a old man with depressive symptom, you're going to see a number of painful somatic symptoms in these individuals. Somatic symptoms appearing early in an individual can also be a marker for late life depression. And also, whenever a person has number of somatic episodes, it's not just having headache plus backache, plus like soreness in the muscles, plus chest pain. There's many somatic symptoms. The increased number of somatic symptoms contribute to increased severity. Similarly, increased number of severity of somatic symptoms can also contribute to severity of depression. So the number of symptoms is important, the severity of symptoms is important. And not only they contribute to the severity of depression, they have very close link with suicidal behavior. People who have attempted suicide with a lived experience of depression, if they've been, helped, and when they come through this, interviews with them have clearly revealed a lot of them have attempted suicide because they had a painful somatic symptom, which is a predominant component of depressive disorder. So having a depression with hopelessness is one. Having a depression with hopelessness combined with a painful somatic symptom increases the propensity and potential for committing suicide. So I think addressing somatic symptoms becomes extremely important. I think if you look at the interoceptive and regulatory challenges across lifespan, this is very, very important, because how people perceive their own bodily feelings, bodily sensations, how they interpret it is pretty much important. In infancy, we are trying to acquire the knowledge of interoceptive, exteroceptive mappings. This is exactly the interoceptive emotional competence takes place while you are an infant. When you come to the adolescent stage, this is a transition to the greater regulatory autonomy. And people are attaining autonomy not only physiologically but also psychologically. In this phase of adolescence, there is a rapid somatic change that is happening in this individual. And here with the rapid somatic change, there are some altered somatic signals. So you will see, even in adolescent depression, some of these people will be predominantly presenting with somatic symptoms rather than cognitive, affective, and other symptoms of depression. So this is easily explained by the interoceptive regulatory challenges that occur in the adolescence period. Another phase in which it's very important is during pregnancy and during childbirth. Again, during pregnancy and childbirth, there is a rapid somatic changes that are taking place. There are regulatory disruptions that are taking place. There is a large change in the social and situational context that is happening in people who are pregnant and childbirth. Here again, people in the puerperal depression, many people present with somatic symptoms. And again, during menopause, again, menopausal depression, predominantly present with physical symptoms, the burnings and other things, because of the altered somatic signals these individuals are going through. So menopausal depression is again characterized by very many somatic symptoms. Again, as I said, when a person has become aged, in geriatric depression, in late life depression, somatic symptoms are predominant. Here is when people have lost their loved ones, that's an external structures have altered, there is an increased inflammation, many of them have gone through injuries and disabilities, and this alters the somatic signals. So if you look at the trajectory during lifespan, during adolescence, during pregnancy, during childbirth, during menopause, and during late life, somatic symptoms can predominate the clinical picture of depressive episodes. This is something that I want to remind the audience. Okay, now that you understood the relationship between somatic symptoms and why they are important, not only in diagnosis, prognosis, we'll understand particularly about painful somatic symptoms, because painful somatic symptoms are clinically more relevant than non-painful somatic symptoms in contributing to severity as well as to the challenge in treatment. Now, all of us know about depression epidemiology. We worry about depression because it's an extremely prevalent condition. About 1 in 6 will experience depression during lifetime, which is about 16%. I think 1 in 16 will experience depression during the past year, which is last year kind of a thing. Look at 12-month prevalence, it's about 6%. So currently, if you look at more than about 300 million people in the world are having a lived experience of depression. Unfortunately, depressive episodes are twice common in women than in men. And the one sad feature about depression is it is a chronic disorder. It's a recurrent disorder, runs a chronic course. So that is why we are worried about it. It's not a one-time illness. It's not a blue that will go away. It's a temporary. We like to believe that, depression is a cloud that will move away with one time. Unfortunately, it's coming back and back. It's recurrent and chronic. And it is the leading cause of disability in the world. Second, I'm sure in about 10 to 20 years' time, depression is going to be the most leading cause of disability in the whole world. Post-COVID, I think people are beginning to realize the importance and burden of depressive disorder. And we talk about epidemiology of depression and combined with pain. That's very interesting. See, the presentation of painful symptoms is extremely common in both depressive disorder as well as in bipolar disorder, bipolar depression. So much so, 95% of the people with the lived experience of depression or a bipolar depression will present with painful symptoms. Particularly, patients with inflammatory and neuropathic pain, we can talk about the other way around. The people with inflammatory pain, people with neuropathic pain are 5 times more likely to develop anxiety or depression than the population. We all know that the close link between inflammation, brain inflammation and depression. In some subtypes of depression, inflammation is a very, very important like pathophysiological factor. So people with inflammatory pain and neuropathic pain are 5 times more likely to develop depression. Again, the severity of depression, as I said very early on in the presentation, is very closely linked to the increased severity of painful symptomatology. If you have increased severity of pain as a presentation, it's going to increase the severity of depression too. Also, depressive symptoms by itself will predict we are going to have painful conditions later on. So if I present with some affective disturbance, some cognitive disturbance, which is part of depression, it's going to predict that I will have a lot of painful conditions like low back pain, shoulder pain, musculoskeletal syndromes later on. So there is a close cross relationship between depression and anxiety, pain. So pain and depression often coexist together and exacerbate each other. This is the most important thing that we need to understand. They seem to have a reciprocal causal relationship. This is like chicken giving egg, egg giving chicken. So pain and depression seem to have a reciprocal causative relationship. And pain increases the likelihood of depression, as I many times said. Individuals with depression and pain have a higher burden of illness than without pain. So that becomes the most burdensome depressive disorder if the person with the depression has indeed a painful condition associated with that. So much about, like the relationship epidemiologically speaking. A little bit about chronic pain, because we work in clinical settings. A lot of people will be coming to us, particularly people work in a general medical setting, doing consultation lies in psychiatry, will often undergo in a situation where people will be presenting to them with chronic pain. We have to be part of the pain management team. So what is chronic pain? If the pain has persisted beyond the normal healing time, and the absence of other criteria, I think we should take is a pain is lasting more than 3 months. Any pain should probably limit itself within 3 months. We should be giving some remedial measures, and I think we should become better in 3 months. Something which is not getting all right in 3 months' time is conceived as a chronic pain. I think anxiety and depression and the related cognitive states, particularly what we call as the catastrophization, really makes the experience of pain very much through both inhibition of modulatory pathways. By actually acting on the inhibition of modulatory pathways, anxiety and depression can have a catastrophic experience in which people feel a heightened sense of pain. People with neuropathic pain generally do not respond to typical analgesics like NSAIDs or opioids. Try and give them, like tramadol to them, or give them a lot of anti-inflammatory agents. People with neuropathic pain are not going to be treated very much by that. The best studied treatment for neuropathic pain is indeed antidepressants and anticonvulsants. You see a whole, market actually marketing that particular antidepressant, anticonvulsants as a way to treat, neuropathic pain. Neurologists live on that. So the chronic pain is a major public health problem with about 20% of the general population affected. It is a chronic pain which has led on to opioid crisis in the Western world. And I think we should also be very, very worried about it, because injurious and improper use of opioids for treating chronic pains, particularly neuropathic pains, is going to be not useful. Indeed, it's going to contribute only to opioid crisis. Clinical studies have stated that chronic pain is often associated with depression. 85% of the people with chronic pain indeed have severe depression. This is something that we all have to know. It's a very, very recent work that's been done in 2019. They say that 85% of the people with chronic pain are presented with severe depression. So really have to understand the coexisting relationship between chronic pain and depression. So I think I'm going to skip the slide because we pretty much talked about it. All I want to say is, when somebody has chronic pain and this chronic pain is contributed by a cycle of increased pain leading to anxiety, leading to sleeping problem, making the person inability to cope with that, again increasing the pain. So there is a vicious cycle going on, and this can impair the life of the person. The person has a general health worry when he has a problem like this. He worries about his work. He's not able to go to work. He's not able to enjoy anything. He's often bound to the hospital. He's frequently in the hospital. His, family relationship is getting worried. There are a lot of financial problems because he's spending so much on medications and other treatments. The medication that he's taking is also hurting him. So there is so much problem associated with the combination of chronic pain with anxiety and depression. So I would say pain, anxiety, depression forms both the psychological and physical vicious cycle. The psychological vicious cycle really is the state of anger, frustration, fear, really contributing to an impoverished mood. And the mood can lead to depression. And depression increases the perception of pain. And the pain is, and then on the other hand, the physical viciousness is the activity is avoided. There is a progressive deconditioning that happens. And the pain leads to decreasing activity. And that leads to further activity avoidance and further deconditioning. And the pain gets aggravated. Actually, people with pain, they don't even move their limb, they don't even get up out of the bed, they don't even go to the toilets, they don't do their regular activities, they are actually homebound and, bedridden, and that could be a physical vicious cycle. This both psychological and physical vicious cycle can actually aggravate the pain. So a good clinician really understands this vicious cycle and starts to deal with that. So I would say by concluding, chronic pain, the most important associated condition is depression, followed by anxiety, panic, sleep disorders, fatigue, and substance use. But I think the most important diagnosis that you would have when a person has a chronic pain as an associated condition is indeed depression. So I've given enough reasons for you to think about and say how somatic symptoms are extremely relevant in depression, how painful somatic symptoms are very important, how chronic pain is strongly correlated with depression and contributes to its severity also. Now, I think it's important for us to allude into the common neural pathways that are there between pain and depression. If something is coexisting together, and I think we need to understand what is the plausibility behind it, what's the reason behind it. The reason is not just psychological, the reason is more neurobiological, because there are common shared neural pathways between pain and depression. Let's simply look at some of the pathways that are there common to both. If you look at the yellow ones are the ones which are important for affective motivational regions. If you look at the cortex, what are the regions which are very important, which drive our affect and motivation? Obviously, the prefrontal cortex, the anterior cingulate cortex, the insular cortex, which is very, very important for our interoceptive abilities, the nucleus accumbens, which is the reward mechanism, emotional rewards can be there, and then the amygdala, which is the emotional brain, and the hippocampus, which is the memory and the emotional memory. So these are the cortical and subcortical structures that are very important for affective motivational regions. If you look at the sensory discriminatory regions, I think what is more important is the sensory cortex, somatosensory cortex, as well as the periaqueductal duct, and then the region, gray region, and then the RVM, postoventral medulla. Those are the ones which are very, very important. And then the descending pain modulation pathways are critically important. So you will see the common depressive pain pathways that are there. Okay. Now, if you look at just the pain pathways alone, we will see the cortical processes that are involved in the pain are pretty much similar to what we have in the affective motivational region of depression. The anterior cingulate gyrus and the insular cortex are two important cortical regions which respond not only to the physiological pain but also to the pathological pain, which is very critical for pain perception and unpleasantness. You see some pain as very severe, you perceive some pain as very severe, and more importantly, unpleasant, mainly because of these cortical regions, anterior cingulate cortex and insular cortex. Whereas the somatosensory cortex is responsible mainly for pain transmission and information that relates to pain modality and location. Where is the pain? Where is my pain localized? What's the pain modality? What's the information related to that? What is the pain transmission? And that is the somatosensory cortex, whereas the anterior cingulate cortex and the insular cortex are the ones which are responsible for pain perception and trying to tell us that it is very unpleasant. The prefrontal cortex is also activated by the pain. The other related structures are hippocampus, because hippocampus captures the pain-related spatial memory and the mood. I think that really captures, when I went there, that's exactly my pain got aggravated. When I did that, this is exactly my pain got aggravated. So I think there is a strong memory associated in the hippocampus, which leads to avoidant behavior. And also the pain-related fear and the anxiety and the pain-modulating behavior comes from the amygdala, because that's where the fear is stored. The endogenous biphasic modulation is coming from the midbrain analgesic neurons in the PAG, and the rostroventral medulla is the one which is exerting the biphasic descending modulation of the spinal cord transmission. And I think the spinal dorsal horn, that's very important. That's the first central pain synapse at the central nervous system. So the spinal dorsal horn, which all study in physiology so much, that's the most important part of the central pain synapse. So this is where many of this, descending modulation may act at the presynaptic and postsynaptic mechanisms. Many of the treatments, local treatments, can be targeted at this level when you're wanting to modulate the structure. So when you look at the chronic pain, and I think while we understand the lower pathways are very important for pain transmission and pain modulation, the pain perception and pain sensitization and unpleasantness is associated with the cortical structures. That's very important for us to understand. Okay, there is a very strong relationship between stress and pain. All of us know when there is a stress, the pain increases a lot. There is a very simple unidirectional relationship between stress and pain. It does not exist. It's actually multidimensional. It's not like just stress leading to pain. There's a very complex relationship between stress and pain. Now, the antidepressant drugs with analgesic effects work equally well in pain patients with and without depression. Whether the person has depression or not, if you give antidepressants, some of the neuropathic pains, even without any depressive component associated with that, they respond very well with antidepressant drugs that we give. And so we also know through genetic and family studies, there is a heritable component which is common between mood disorders and chronic pain. So there are also other, personal factors, which are also contextual factors, which are also common between both chronic pain and, depression. As I always say, inflammation is going to be a very important factor for psychiatrists in the future. Chronic inflammation can actually lead to both pain as well as depression. Neuroinflammation is responsible for a subtype of depressive disorder. Many of the biological markers of depression includes inflammatory markers. Tomorrow you'll be able to have a panel to make a diagnosis, a robust diagnosis of depressive disorder. That panel of biological markers, biomarkers, will include inflammatory markers, because inflammation has a very strong relationship with pain as well as depression. And that could be the link between pain and depression. We all know that how stress can induce, even in a euthanic vulnerable individual, inflammatory things, and pro-inflammatory cytokines can be released. They lead to a lot of disturbances at the neurotransmitter level, which can lead to major depressive disorder. That's a kind of hypothesis for inflammatory hypothesis of depression, and we believe in that. That's a common pathway for both pain and depression. And we all know in terms of a neurotransmitter level, the 5-HT and norepinephrine are not only important, these monoamines are not only important in the pathology of a depressive disorder, but also equally important in chronic pain. So in chronic pain as well as in depression, both norepinephrine and serotonin has been implicated. Pain originates in the primary sensory neurons, and it actually ends in the dorsal horn of the spinal cord. It is in the dorsal horn, the pain cells signals are activating the brain structures through the ascending pain pathway. The final result is a pain manifesting clinically. So a dysfunctional serotonergic noradrenergic system in the spinal cord is likely to have a dysfunctional descending serotonergic or noradrenergic pathway, which explains in many of the patients there is a comorbid pain and depression. That's why we want to give antidepressants to manage both the conditions. So we do know that through a lot of neurobiological studies, there is a very strong neuropathological factors that combines. That I am very fond of talking about in any meeting. This is one of my favorite slides in any meeting on depression. And I think we need to understand the same pain structures that I talked about are implicated in the neurophysiology or neuropathology of depressive disorder. Let's look at the neural systems that are relevant to depressive disorder. Look at the subcortical structures. Amygdala and the ventral striatum are responsible for our emotional and reward processing. So we get a reward, we feel very happy about it. At the end of my presentation, if I feel good that I've done a good job, if the child is going to appreciate it, I'm going to get an emotional reward. The amygdala and ventral striatum are the one which is responsible for the reward mechanism to make me feel happy, and I get registered there. And then sometimes we get up in the morning. I got up in the morning with a very nice feeling. It's the second day of the conference. Even though I'm missing the conference, I'm getting excited that I got 2 presentations to go on. I'm going to be talking there. So you get up in a better mood. Some days you get better, you get up in bad mood for no reason. There is something called automatic regulation of emotion that occurs in every individual. One morning we get up with the bad mood, one morning we get up with the negative mood. It happens very often in depressive disorder people. They get up in the morning for no reason, they feel sad. For no reason, they feel gloomy. So the structures that are responsible for the automatic regulation of emotion are the medial structures of prefrontal cortex and the anterior cingulate cortex and the orbitofrontal cortex. The orbitofrontal cortex, anterior cingulate cortex, and the medial prefrontal cortex, which are all medial structures, are important for the automatic regulation of emotion. Whereas the lateral structures, the ventrolateral and dorsolateral prefrontal cortex in the cortical region, are the ones which are responsible for the voluntary regulation of emotion. I have something good happening, some great environment I'm in Madurai, talking to my friends, connecting with people, having a good socialization in the evening. I feel good. That voluntary regulation of emotion is actually contributed by dorsolateral and ventrolateral prefrontal cortexes. Please remember, these are going to be the most important substrates which become the targets for your intervention in future through deep brain stimulation or through RTMS or even through ordinary, brain modulation techniques. So we have now to learn the surface anatomy to know where the neural substrates of depression are and to target them appropriately, not to be blamed about what you are dealing with. So similarly, if you do the neuroimaging of pain, these are people who have been done neuroimaging of pain. And remember, what are the structures that show up in the neuroimaging of pain? These are clustering occurring in the somatosensory cortex, which is important for pain, transmission and localization, and prefrontal cortex, anterior cingulate cortex, and thalamus, which is the junction. All psychiatric disorders are in the cortico-thalamic striatal, circuits. So thalamus is the junction box through which the cortex is connected with the subcortex, and thalamus is very important for pain modulation too. So even in the neuroimaging of pain, there are overlapping structures. All I want to emphasize here is, if you look at the neural pathways of depression and chronic pain, there are overlapping cortical areas and subcortical areas, which is why these two conditions coexist together. And I just talked about corticostriatal connectivity. This connectivity actually predicts whether somebody will have a transition from an acute to chronic pain. If you have a circuitry disturbances in this corticostriatal functional connectivity, a person who is experiencing acute pain will move on to a chronic pain. It's almost like a predictor. Similarly, a brain white matter structural property, we can actually do it by imaging these days. There are very good ways of imaging white matter pathology. And I think pre-existing white matter structural abnormalities will also predict some people will become, pain will become chronic in this individual. These are the people going to transit from an acute pain to chronic pain over a period of time. Similarly, the frontostriatal gating is very important, not only for chronic pain, but also for conditions like tinnitus, which also require sometimes psychological management. So the new insights that are coming are that there are common pathways between mood and chronic pain, and histologically speaking, there is a structural foundation that lays the reason why there is a coexistence of pain and depression. The insular cortex, the prefrontal cortex, the anterior cingulate cortex, the thalamus, the amygdala, hippocampus are common regions for both mood and chronic pain. So I think since we understand there are similar things between stress and depression and pain, and there are common overlapping neural pathways, we can reasonably conclude the understanding behind coexistence of pain and depression. Finally, what do? We thought about the relationship between somatic symptoms and depression, how somatic symptoms are common, number and severity contribute to severity of depression, prolong the duration of depressive disorder as well as severity, contribute to suicidality, and we know that they can influence diagnosis, prognosis, and treatment. We know the common neural pathways between mood and chronic pain. Now we come to the pharmacological management of depression with somatic symptoms. What are the treatment options we have? Treatment options we have are limited to tricyclic antidepressants. I think many of the youngsters don't even use tricyclic antidepressants these days, but some of us, who've been in this trade for long periods of time, been very familiar using the gold standard drugs, using tricyclic antidepressants, are still comfortable using tricyclic antidepressants. The largest market for TCAs are actually coming from the old generation psychiatrists. But I just really want the younger generation psychiatrists also to think about TCAs, particularly when it comes to somatic depression. When somebody is presenting with depression and somatic syndrome, TCAs like amitriptyline, nortriptyline, doxepin, dozulipin may be a great choice. SNRIs. I think people use SNRIs very popularly. Venlafaxine, desvenlafaxine, duloxetine in particular, and milnacipran very recently. And then, L-milnacipran has come recently. These are the drugs that can be used in somatic depression. Psychotherapy is also very important because, we have to make people to learn to live with their pain. They can't be indulging in avoidance. They should know how to cope with the pain and learn to live with the pain. That's a very important, thing that you do in pain clinics. So what do? I think we need to recognize the simple fact in patients with chronic pain, depression and anxiety is extremely common. That is, I said, 95% of the people with chronic pain will have ulta. Also 85% of the people with depression will have chronic. So both will happen. The perception of severity of pain increases the depression and anxiety. In turn, pain perception also increases depression. So there is a vicious cycle. We understood that. So remember that while managing. So the tricyclic antidepressants can actually help all the three. It can deal with the pain, it can deal with the anxiety, it can deal with the depression. The triad of anxiety, depression, and pain can be effectively managed with tricyclic antidepressants. Because tricyclic antidepressants have a very good anti-anxiety property, have a great attenuating property to reduce pain because of their ability to increase the levels of both serotonin as well as norepinephrine, right? So because of their action on both the amines, both serotonin as well as norepinephrine, they are most likely. Let's give an example. Somebody present with depression with somatic syndrome, if I was a clinician, I would actually begin with a tricyclic antidepressant like dozulipin, which is my favorite antidepressant. 25 milligram in the night I will begin with. I will slowly step it up to 75 milligram. I can go up to 150 milligram. Generally, a dose between 75 to 150 milligram of a tricyclic antidepressant like dozulipin is very safe as well as effective. So we find it to be not only safe but also very effective. The only common side effects that I see in tricyclic antidepressants, particularly like dozulipin, are the anticholinergic side effects. Dry mouth and constipation are extremely common. We need to educate the patient. We should warn them early. We should, tell them so they're prepared for it. They don't get alarmed about it. And orthostatic hypotension can occur with older individuals. It asks them to, change the pastates very slowly because, the changing pastate suddenly can result in, giddiness and falls. So you can continue for a period of up to 6 to 8 months and more, even longer, till you obtain the proper remission and look for a, recovery. So recently we embarked on a clinical trial with dozulipin for people with refractory depression to conventional SSRIs. These are people who have failed with the conventional treatment with SSRI for a reasonable amount of dose and duration. And we took them for a trial in Chennai and Odisha. My friend Amrit Patojoshi and myself did the trial. We got it published and it is available as a publication. We did realize dozulipin, a forgotten molecule by youngsters, is extremely useful, not only reducing depression significantly, also alleviating anxiety in a very significant way, also sleep promoting and addressing somatic symptoms in the depressive scale. So it's a very, very important drug that is very still useful. And most of the times we use a dose of about 75 milligram dozulipin. With that dose itself, a lot of people showed significant improvement. These are people who did not respond very well with the SSRI, at a partial improvement or a no improvement. So the other alternatives that are available to dozulipin, like drugs, TCAs, are SNRIs. Particularly among SSRIs, my choice would be on duloxetine, and venlafaxine can also be very useful. And duloxetine very often used by diabetologists for treating neuropathic pain. So along with pharmacotherapy, as I said earlier, we need to really help them with pain reduction through psychological methods. Improving the functioning is an important goal in pain clinics. I think we look at and say the most guidelines recommend TCAs as a first line of treatment for chronic pain, whether it is the ACOM guideline of 2014, ICSC guideline of 2013, NICE guidelines of 2013. All of them recommend TCAs as an example for managing chronic pain. The question then comes is, what is your choice? Is it dozolipine? Is amitriptyline? That's a choice that we always ask, and I think the results are very simple. Dozolipine is as good as amitriptyline in treating both depression and pain. So it's actually equipotent when it comes to comparative results with amitriptyline. And then, but the side effect frequency may be much less compared to amitriptyline. Amitriptyline, has a very significant anticholinergic potential. Among all the TCAs, amitriptyline has the highest anticholinergic potential. That's one of the reasons why it's not become very popular. But I think dozolipine has much less anticholinergic potential relative to amitriptyline. In our own clinical trial involving about 90 people, there will be no discontinuation purely on the basis of anticholinergic potential, because we gradually titrated the medication up. I think people are able to tolerate the medication better, including the anticholinergic side effects. I think in the single-blind comparative study that was done between dozolipine and equally divided daily dose of amitriptyline, I think the side effects were very less, and the greater improvement, even though it happened, with dozolipine better than with amitriptyline, because I think discontinuation is a combination of tolerability versus efficacy. The drug may be efficacious, because of side effects people may discontinue. So the discontinuation is a very important phenomena that does not happen so much with dozolipine compared to amitriptyline. If you look at TCAs and SSRIs, I think if you look at the number needed to treat with the TCAs, it's only 2.4. The number needed to treat with SSRIs is 6.7. We are all very well convinced about SSRIs because of this lesser, side effects. That's why we are all using SSRIs. But in terms of efficacy, you have to understand TCAs require a smaller number needed to treat, which means it's more efficacious than SSRIs. This is coming from randomized controlled trials. So again, one of the important side effects of SSRIs is the gastrointestinal symptom. A lot of people will have severe gastrointestinal symptoms, land up with a gastroenterologist with nausea and with severe abdominal upsets. And I think in contrast to SSRIs, TCAs have much less incidence of gastrointestinal side effects. So that is something that you can look at it favorably. Again, in terms of Cochrane evidence, and I think head-to-head comparisons, dozolipine is better tolerated and more effective than fluoxetine. This is Cochrane's review. So if you look at the comparative analgesic efficacy of different antidepressant drugs, if you look at TCAs, I think the number needed to treat for pain in the value of pain attenuating property, the number needed to treat with antidepressant like tricyclic antidepressant is only 3.1, compared with SSRIs, which is 6.8, and SNRIs, which is 5.5. So the comparative analgesic efficacy among the antidepressant drugs is superior to drugs like dozolipine, which is a tricyclic antidepressant. So in terms of conclusion, I want to say, I know I've taken a long period of time, but I want to say chronic pain and depression, they have a reciprocal causative relationship. One is reinforcing the other. Often they coexist together. And the coexistence may be simply explained by a common maladaptive neuropathological mechanism behind it, in the cortical as well as in the subcortical and the junction region. And these changes are our potential target for intervention molecular-wise. That's why we give them tricyclic antidepressants as a way of treatment. And effective treatments in future also should be looking at these targets in order to reduce the significant burden that is associated with comorbid pain and depression. A day will come when brain modulation techniques will be there, which can specifically target these neural pathways and modulate both chronic pain and depression. Thank you so much. I'm happy to take any questions related to that.
Thank you, Dr. Suresh, for a wonderful presentation. I think most of our patients learn to live with chronic pain and depression. I just bumped into one of my patients in the airport, and then he told me, or painfully remembered that I treated him 20 years back, and he was telling he has been living with amitriptyline and his wife, and he has been managing both, and that's what he was, jokingly mentioned. And I think many of our patients also, they learn to live with the depression and pain. The challenge, as I said, is that very difficult. It leads to chronicity, relapse, and then remissions, and then they come back to us or change a psychiatrist. They do short doctor shopping, they go to a general practitioner or a specialist, and then they come back to you and all those things. Like Suresh mentioned, it's a very, very challenging thing. But TCAs or SSRIs and some of these SSNRIs seems to be acting well and all these things. Now, what I will if there are any questions from the floor, I think Dr. Suresh is waiting. Thank you, Dr. Suresh. I failed to introduce you. Maybe, because you don't need introduction, perhaps unconsciously I must have thought and all these things. Are there anybody from the floor who want to ask any questions? Or most of us, it's not something, every one of us come across this problem. And so any challenges that you come across or any clarification that you need or question, Dr. Sureshkumar, the floor is open for discussion. Yeah, please come to the mic, please. Please identify yourself.
Sir, I'm Dr. Sunita from Trichy, Ramya Hospital. I have been working in consultation license psychiatry. I'm attached to a gastrocare center. So what I have seen, according to the way I have treated patients with abdominal pain as well as depression, is they respond to SSRI plus small dose of tricyclic antidepressant. I am not very sure whether this way of treatment is right according to your opinion.
Dr. Suresh?
Doctor, sorry, I didn't get your name.
Sunita.
Dr. Sunita, there is nothing right or wrong. It's very inappropriate for me to comment on what you did because you're a qualified psychiatrist. You know the person with the lived experience who's in front of you better than me. But my logic is, if you are going to treat pain, which has an origin transmitter-wise, not only in the serotonergic, but also in the norepinephrine molecule, you would be better off choosing a dual-action drug rather than a single-action drug. So that's the logic of not wanting to give SSRI and preferring SNRI or a tricyclic antidepressant. Now, another reason why I would not want to give an SSRI for a person with an abdominal pain, SSRIs are notorious to produce gastrointestinal symptoms. Most of the gastroenterologists will tell you they've had very severe cases of even internal bleeding and other things. Yes. When they do an endoscopy, they found so many things. When somebody has been put on a drug like escitalopram or acetylcholine, people can have serious gastrointestinal side effects if you're not been very careful about them. Because sometimes patients don't relate the gastrointestinal symptoms to the medication that they've taken. They go independently to the gastroenterologist for a complaint. And then the gastroenterologist sometimes don't look at the psychiatrist's prescription. So only later on they figure out that medicine could be an offending agent. So what I want to tell is, you may be well off in choosing a drug which acts both. Anyway, you're giving a tricyclic antidepressant. Why not fully try only tricyclic antidepressant? What is the fear of giving tricyclic antidepressant in adequate optimal dose? So what is required to treat pain and depression is an adequate optimal dose. Please remember, pure pain management requires a less of a dose. Depression management requires a higher dose. For example, if somebody only has pain, no depressive component associated, that person requires a smaller dose. For example, neuropathic pain. You actually treat neuropathic pain with 10 milligram amitriptyline, 25 milligram dosulifin, 10 milligram nortriptyline. That's the kind of dose you use. Whereas somebody has pain and depression combined together, you need to use little larger dose, which is an optimal dose. I would rather use 75 milligram dosulifin, and that's what will be helpful to them. I would, in my opinion, stick on to one drug that can target both serotonin and norepinephrine, rather than choosing an SSRI which acts on serotonin. And then, where we did, in our clinical trials, sometimes, we add SSRI plus dosulifin only because the person after starting serotonin drug like SSRI has benefited, not completely but partially, because it is refractory, he was not responding properly. We didn't want to lose the gain that we had with SSRI, so we added a tricyclic antidepressant. That is logical. If that's the reason why you started off with SSRI and then you found that it's not responding, adding a tricyclic antidepressant, you are completely justified in doing that. We are doing it for the first time. You know that's a chronic pain and depression. You can actually confine only to an SNRI or to a tricyclic antidepressant of your choice. Hope that has answered your question, Doctor.
Yes, sir. Yes, sir. Thanks a lot.
Thank you, Sunita.
Sir, I am Dr. Endumadi. In continuation of this thing, duloxetine as a solo antidepressant, your opinion, sir. Thank you.
You want my opinion on duloxetine?
Yes,
Duloxetine, yeah.
as a single antidepressant.
It's a good drug. Only thing is, in Indian population, it's not done so well as it has done in the Western population. You go to UK, in the geriatric group, that'll be the primary drug people will be giving. Anybody in geriatric group, that's where the somatic symptoms are extremely common. I think the drug that they prefer in UK is probably duloxetine. So many people get duloxetine. Whereas in India, if you give 30 milligram duloxetine to a person, sometimes the soporific effect is so high, and I think people fall and injure, and then you really are shattered by it. So I think it is the soporific effect of duloxetine that could be a deterrent for this particular person. But I think, for it to work as an antidepressant, you might require something like 90 milligrams sometimes, and you really require. People who tolerate duloxetine, I've seen in my clinical practice who tolerate duloxetine, with somatic, component with depression, with 90 milligrams, they do very well, 60, 90 milligrams. And, I think only thing is you need to really go slowly and titrate it down. And diabetologists are very fond of giving it as a neuropathic pain. And I know that, they are fond of, many drugs, one of them is duloxetine. I think among the physicians, I think nortriptyline, dozolapine, duloxetine, amitriptyline are all very popular for dealing with neuropathic pain, all in smaller doses. But when it comes to pain and depression, which is our baby, I think we need to be considering either TCAs or SNRIs.
When we are augmenting with duloxetine means which one will be preferable, sir? Suppose
Augmenting?
with duloxetine. So duloxetine we want to keep, but same time it is not effective or not tolerable, so we want to add something else, means what could be the better option along with duloxetine?
You want me to add idli with dosa? So, one SNRI with another SNRI. I think ideally speaking, we'll have to titrate up the dose. The problem with medication is, you don't have to be aggressive. You can explain to the patient. I always believe in the philosophy of start low, go slow. Start low, go slow, probably you'll achieve whatever you want to achieve, rather than be aggressively putting on cocktails.
Thank you, sir. Thank you.
What about mirtazapine, Suresh? Of late, people have been talking about.
Sir, my clinical impression about mirtazapine is among all the antidepressants, it is the low potency antidepressant. That doesn't really work very good as an antidepressant, but extraordinarily good for people who are, having stomach issues. I think when somebody comes from a gastrointestinal visit and complains, I think that's the drug I choose because it's very gastrointestinal friendly. The only problem is for a woman, I am very, scared to give it because I gave a very slim, beautiful looking Nellore girl. 8 months later, she came and said, I have a pistol, I would have shot you down. You cut me again 10 kgs of weight, all because of mirtazapine. So, so very wary of giving mirtazapine to young people because they put on so much of weight. And I think it increases the weight. Where it is very useful is in the medical setting. And I think when they have medical problems, and I think people with cancer, for example, cancer with depression, they have no appetite. And that's the people I want to give, HIV people with depression. That's when I really give mirtazapine because it increases appetite.
Yeah.
Dr. Ravi Shankar from Salem. So how long to continue if both pain and depression are present? The medication, when to stop?
When to stop treatment? That's $1 million question. The opinions vary. When I don't know the answer, I put the answer as vague as possible. You know what? I want people to achieve remission first. And I want to keep them in the period of remission longer. If it is a first episode of depression, I can take the choice by taking it not more than a year. But if it is 2 episodes that occur, I would like to prolong the duration. If more than 2 episodes, I would like to think that they will be better on a long-term duration, sometimes lifelong. But I don't want to talk about it to the patients. People will come and ask, how long should I take? Is it lifelong, doctor? I always joke around and ask them and say, whose life are you talking about? Your life or my life? If it is my life, it is shorter. If it is your life, it is going to be longer. You decide whichever is lifelong. So I think it's a very tricky question. The scientific answer is sometimes very difficult to communicate. I think more than 2 episodes, literature is telling they require a long, long treatment. Even though nobody has arrived at a consensual statement on that. But we know that at least people may require 2 to 5 years of treatment. We all understand that depression is a chronic disorder. Chronic disorders require long-term management. But communicating that to the patient is going to be the most difficult one. Particularly when the illness is of an episodic nature, when they're going to be having long periods of, like remission, those are the periods which are difficult to convince for them to take the medication.
Is it true that the MRC trials say that at least a minimum period of 2 to 5 years you have to treat
Yes, sir.
depression?
Yes.
Yeah, Raman.
So, Dr. Ramanujam from Tirunelveli, thanks for a wonderful session, sir. What is the role of non-pharmacological measurements in depression with somatic, especially exercise, progressive muscular relaxations?
Sir, I think you asked a very important question. I've definitely been very, very restrictive in my presentation by excluding both psychological and behavioral management, as well as the somatic therapies. Both I've excluded. Let me say something about psychological management. You talked about relaxation. Relaxation is very important because it's going to reduce the component of anxiety, because it contributes to the vicious cycle of pain. So reducing the anxiety is very important. But I think pain clinics concentrate a lot on behavioral techniques and cognitive techniques, because I think the way they catastrophize the pain is very important. The way the pain perception is important. The way they are sensitive to the pain is important. They talk about pain. You sit with a person who has a chronic pain, 6 hours they can talk just about the pain that comes from their abdomen. The way they vividly describe, the way they go about describing it so much, my God, I think you need to be really patient to listen to them. And I think this is basically because their interoception is very different. Their insula is so active. They are so much perceiving the pain, and they are so sensitive to the pain, and they are all the time preoccupied with that. So the catastrophization relating to that has to be changed by cognitive strategies. I think this behavioral activation, avoidance has to be, it's a kind of a behavioral deconditioning that has happened. So you need to revert that. So combination of psychological, cognitive, behavioral interventions are critical in pain management clinics. I think we have seen some excellent pain management clinics in the West, and I think they pay a lot of emphasis on behaviorists and other cognitive therapists playing a significant role in pain modulation. And not to think that, it's a teamwork. It's always a pain management, a teamwork. Psychiatrists, psychologists, and other people, anesthesiologists, all of them come together to play a role in the pain clinics, chronic pain clinics.
I think combination is better, I think, so because your psychotherapy works in the daytime and pharmacotherapy works in the night, I think. Okay, next.
Good morning, sir. Dr. Rajesh Kannan from Theni, sir. Thank you for the presentation, sir. My question is about regarding use of opipramol as an augmenting agent in somatic complaints.
Yes, after all, it is a tricyclic antidepressant. We are putting the old wine in a new bottle and selling. Opipramol is the old antidepressant. Actually, it was marketed in the Europe way back, as good as Imipramin, and at that time it was marketed. For some reason, it never found its way to India. Suddenly, people had a great marketing strategy to introduce a old wine, in a new bottle. So obviously, any tricyclic antidepressant, which is a dual action drug, will work against chronic pain, against depression. So that's going to be useful. I don't find it superior to any existing drugs. I think still, in my opinion, the gold standard tricyclic antidepressant for management of depression is TCA, like Imipramin, period. I don't think anybody will dispute that. No other drug has got a better efficacy than the conventional tricyclic antidepressant. Look at the number needed to treat depression. You will see remarkably small numbers in TCAs only. The only reason they have gone out of vogue by young psychiatrists is the toxicity that is associated with that. The toxicity is the one which has scared people in the Western world primarily, because people get a medication for about 4 weeks, 8 weeks, and at one go they take the medication and then they go off. Surprisingly, in India, overdose deaths related to antidepressants like tricyclic antidepressants, even in our days when we prescribe, is so less. People didn't think that it can kill them. They actually would take a benzodiazepine to kill themselves rather than a dose of antidepressant. That's a sad thing. That's a good thing in a way, that I have not seen many overdose with antidepressants, except in a very close friend who actually consumed, a big dose of antidepressants because he knew that it can kill her. The knowledge made her to swallow it. But otherwise, most people attempting suicide will take innocuous benzodiazepine of, 60 tablets of benzodiazepine, diazepam, alprazolam, or clonazepam, sleep it off well in ICU, pay the money for the private clinic and come back safe. So I would say that tricyclic antidepressants are gold standard treatment even till today for treatment of depression with pain.
Thank you for active participation. I'll allow only one question, maybe, Doctor. Yeah, thank you.
Dr. Rabindranath, wonderful presentation, Suresh. I just want to ask a question. Sometimes as psychiatrists, we need to take a decision on patients who present pain as an illness behavior, whether to continue the treatment or not, or whether to stop the treatment, because he's very comfortable, he doesn't have any responsibility, he need not do anything because of the pain problem, and he continues to take the tablet. The parents are worried about it. We know very well it's an illness behavior. Do you have anything in armamentarium to manage people like that? With your experience, you may have come across such two patients. Do you have anything in your armamentarium to treat them?
I actually, as a clinician, I'm very challenged to manage people who come under the category. Thankfully, they don't. It's easy to manage pain, depression, because it's a clinical conundrum which is very different. It's got a biological basis. Whereas the one that you're talking about comes under a different category of people with, somatic symptom disorders. And these people who have this pain behavior rather than pain itself, it's a pain behavior. Their preoccupation with pain, they're thinking all the time about pain, and then their behavior relating to pain, which is a completely different group of, like a disorder. I think that's the most difficult disorder to deal with. I think, we are heavily challenged. I think in the TAN Psychon, they allocated a lot of things for that. There was good sessions about how to manage this kind of things. I would say as a clinician, I'm very challenged to manage. I'm really equipped to deal with that. I think we're required a team to deal with those people. And I think this wooden leg people, who just say, I need a crutch to walk, I can't walk, I'm rather be bedridden, help me, this is what I'm comfortable with. This is a very, very difficult situation, and pain behavior is a challenge, but we can't give up. I think it's not just the sole responsibility of one psychiatrist. A team of people helped by a good team would be the best solution to those people. They require a lot of workup. We can't give up on them. I believe that we need to change their pain-related behavior in a very sophisticated, complex, comprehensive way. Thank you, Dr. Rabindranath, for asking this very challenging question.
Thank you, Dr. Suresh. I think I should thank the audience for a very active participation in this. Thank you so much. Who will get it? Thank you, Dr. Suresh, for the wonderful presentation. On your behalf, I will receive, or I will ask Dr. Srinivasan to get it and possibly hand it over to you once again.
Thank you, sir.